So carry on our agenda. We broke a little bit early because there was some really good conversations this morning. So we're just at item 11, which is developing a local vision for sustainable general medical services. So we've got a presentation and got a couple of members of staff along to help us through it today. So with that, I'll hand it over to David to introduce it and we'll see how we go.
Yeah, I'm just going to say a few words by way of introduction this and then
Sorry, I can't hear you, David, sorry.
Sorry, I was probably talking out my hand there. Yes. Yes, so I'm going to say a few words in introduction, then I'll hand over to Jill and Lisa, who have been all with us. So, colleagues will remember back in December, we brought forward, Gracie and I, a proposal to review general medical services, and this was very much with a view to recognising the sustainability challenges that have been in the Increase in Galloway for many years, and the number of practices that have come into direct board management over that period due to partners retiring and an inability to secure new partners into the area. So a piece of work that we promised to do to look to see how we can make our general medical services more sustainable across the region. We agreed that we were going to start by scoping that work out and agreeing with local GPs, local GP practices, but also wider stakeholders such as our service directorates and community councils as representatives of local communities as to what they were looking to get from a review of sustainability in general medical services. We have promised to bring back a scope to this very meeting. We're not quite there yet because the conversations are very much ongoing, and I think the levels of engagement that we are seeing emerge will stand us in good stead. It will not affect the overall timeline for this project. We will still be looking to deliver 1 year in 1 year's time what the future model of general medical services looks like for the local area. Since we met, we have formed a bit of a team around this work. So Jill from my team, Lisa from the PMO, working very closely with Linda Bunny as the general manager responsible for primary care, and Gracie Bell as the Associate Medical Director for Primary Care, and obviously Medical Director as well. And recently with Rod and with John Wilkes from my team as well, to make sure that we've got comms and intelligence around this as well. So we've been coming together as a team, supported by our business support colleagues in terms of Gracie, to make sure that we have all the right skills and competencies available to us. Learning lots from the review of Right Care, Right Place and the lessons learned from that. So we are getting to a good place with this work. The engagement is now underway. We already have quite significant amounts of feedback back from general practice in particular. And Lisa and Jill are just going to talk us through the process that we've been following thus far and some early feedback in terms of the themes that are coming through with that commitment to bring the full scope back next time.
Thank you, David. Presentation for that? Yeah. Thank you. Not sure we need it now, David. I think that was quite succinct. Brilliant. So I'm Gillian Copeland, Strategic Planning and Commissioning Manager, supporting this work, as David said. So we're here to present on building a new future together, shaping the future of general medical services in Increase in Galloway on using the service review framework. So as David said, this update will cover progress, current engagement and next steps. So the review follows the service review. Oh, next slide, sorry.
Everyone see it all right? Should we go to full screen?
Yeah. Thank you. Brilliant. So this review follows the service review framework, which ensures a structured and evidence-based approach. The timeline has been adjusted to reflect the need for thorough engagement and stakeholder input, leading to a refined scope in June 2025. General medical services remain the foundation of primary care, facing challenges like recruitment, increasing demand and evolving patient expectations. Addressing these challenges is crucial for ensuring sustainable services. Next slide, please. So, mandate and proposal submission. This stage established the overarching aims of the review, defining key objectives to guide the process. High-level sponsorship secured approval to proceed, ensuring alignment with national priorities. A structured proposal was developed outlining key resource requirements and governance oversight. Next slide. Okay.
So the scope focuses on how GMS services can be configured to meet future needs within that existing contractual framework. It considers the local priorities, the workforce sustainability and service integration, ensuring alignment with the broader health and social care strategies. Next slide, please. The data is currently being collated from engagement activities with GP practices, stakeholders and the public. Themes emerging include workforce challenges, service integration issues and digital transformation opportunities. Next slide. Stakeholder engagement remains a priority with structured discussions involving GP practices, the multidisciplinary teams and wider health and social care partners. Public engagement is still in development with the communication and engagement group, as David mentioned, supporting the approach to ensure effective outreach. The third set of questions for the public is in the process of being finalised, and further planning will shape how best to gather and incorporate that public feedback into the review. Next slide.
So our initial analysis of engagement feedback is underway, focusing on synthesising data and stakeholder input from GP practices, wider stakeholders and some early thematic responses. The goal here is to distill key insights into structured themes that will inform the future direction of service planning. Several key themes and drivers are already becoming apparent. Workforce retention challenges, increasing patient demand and digital transformation needs are emerging as consistent priorities. Additionally, a lot of concerns around service integration, operational pressures and resource distribution are frequently highlighted in responses. Moving forward, this analysis will be used to prioritise opportunities for improvement, ensuring that proposed changes are realistic, evidence-based and aligned with both strategic objectives and operational feasibility. Thematic insights will continue to evolve as engagement progresses and more data is collected, helping to refine the scope and shape the direction of the GMS review. Next slide, please. So this analysis is based on 26, this is the early intelligence, it's based on 26 responses from a broad cross-section of our primary care workforce. As you can see from the slide, the respondents include 12 GP partners, a mix of salaried GPs, various MDT staff, including life workers and advanced practice practitioners, as well as practice managers and administrators. This diversity ensures that our early feedback captures a wide range of perspectives and current challenges and opportunities within our system. This early feedback has also been invaluable in identifying unintentional barriers within our data collection tools. Based on both verbal feedback and responses via the Microsoft Forms, we have made targeted tweaks to remove these obstacles, ensuring that our tools better support broad engagement and capture a wide range of perspectives going forward. Next slide, please. So from early analysis, 6 key themes have emerged that aligned with our anticipated review focus: service delivery, workforce, digital, data, premises and quality. Each theme reflects core concerns expressed by respondents. For instance, while service delivery highlights the need to manage rising patient demand effectively, workforce challenges underline persistent staffing issues and the importance of professional development. In the digital category, respondents are frustrated with system inefficiencies, and in data, they stress the need for seamless integrated information sharing. Additionally, the responses consistently emphasise the importance of underlying principles such as equity, integration and sustainability. An emergent theme that has become apparent is the critical need to balance advanced digital tools with the preservation of essential personal interaction. So while digital solutions can streamline processes, they must enhance rather than replace the personal touch that is fundamental to primary care. This early intelligence provides a robust foundation for our review, and it validates our focus areas and will guide the subsequent stages of thematic analysis and consultation.
As we transition into the next phase, consultation will play a crucial role in refining our findings. We will share emerging insights with key stakeholders, enabling them to validate the themes and provide additional feedback. This iterative process ensures that we co-produce a meaningful vision for the future GMS services, shaped by the real-world experiences of those delivering and accessing care. Next slide, please.
Final recommendations will be developed based on engagement findings, thematic analysis, and an equality impact assessment. This phase will also involve reviewing all feedback from stakeholders, assessing feasibility, and ensuring alignment with national and local strategic priorities. The recommendations will then be prepared for review and approval by the IJB, ensuring that the proposed direction is evidence-based, sustainable, and implementable within the GMS framework.
So this timeline outlines the main phases of the review process. In June of this year, we aim to present a refined and detailed scope back to the IJB, and then subsequent phases will allow more for targeted workshops, broader consultations, and then a final review phase before leading us into that action planning and implementation next April, from April 26th. Slide. So where are we now? We are currently in the engagement phase of the scoping stage, and we're actively gathering detailed input from 3 different groups, as we said, particularly GP practices and their practice teams, the wider stakeholders and the public. The engagement questions approved here in December are tailored for the GP practices on one hand and for wider stakeholders on the other, with a dedicated third set developed for the public. Feedback so far has indicated that some respondents, as Jill alluded to, were finding the questions somewhat laborious and onerous. So we have tweaked their presentation and wording just to try and encourage that richer, more kind of accessible responses. And that seems to have hoped. Our consultation and engagement group, together with support from our communication engagement manager, Rod, is playing a key role in this process. In addition, we are providing resources such as frequently asked question flyers, a visual depiction of the process, and also a leaflet with a QR code to try and make it a bit easier, linking it directly to the forms to facilitate that feedback a bit easier. While it's iterative and evolving, and sometimes does feel a bit muddy, we view this as a positive sign that we're actively listening and adapting to ensure that the insights gathered will effectively shape the future configuration of GMS services within that established contractual framework. Next slide, please. So next steps. The next steps involve completing the current engagement phase, continuing to refine the insights from the responses, and preparing for that presentation of the refined scope to IJB in June. This stage will incorporate thematic analysis of all the feedback received to date, ensuring that key themes and emerging trends are clearly identified. Following the IJB review and approval in June, the focus will shift to the planning phase, which will include our more structured workshops to try and further refine and develop the service delivery models. These workshops will draw from successful approaches used in other board areas, and will provide a platform for stakeholder collaboration, ensuring that the evolving vision for GMS is practical, sustainable, and aligned with local needs. Further engagement and validation of proposed approaches will follow, leading towards the development of an information plan from April 26th onwards. Thank you.
Thank you, Commissioner McKeown.
Can I just say one thing? It was a brilliant presentation, guys. Really helpful. The thing that came into my head as we were going through that was a conversation that has evolved with the local medical committee and GP subcommittee around this work. But it was undoubtedly in the early days an anxiety that we were going to somehow redefine the contract. That's not what this was. The contract's set nationally. So we are not focused on what general practice delivers. We're focused on how general practice is delivered in a way that's right and sustainable for Dumfries and Galloway. And I think it's really important that we say that in a public meeting such as this, so that that's formally on the record and colleagues can then be assured that we're all on the same page with that. Thanks, Chair.
Okay, thank you. Mark?
Yeah, I think that's a helpful clarification, David, and was one of my questions, but I think a really good presentation and a really good way forward. I think for me, I'm absolutely clear a real rigorous review of the GMS services are a route to renewal. You know, the community is absolutely where the solution lies. So for me as well, it's not just about that staff involvement, I'll be listening to the public as well. I think my plea would be, let's be bold and innovative in this space. We talk a lot today about being bold and courageous. This is a place where we need to be absolutely bold and courageous. So, you know, let's get to the end of the process and we can come back with some tweaks and doing this a bit better. I want to really be able to see how we're going to do things significantly different, because we know that right now, while that general medical service space works for a lot of people, it's not working for a lot of other people for the reasons that we know about. We're also pretty clear from my clinical perspective that the digital first has got to be a leading way out of this as well. So that would be my plea. And the other thing is, are we learning from other countries? What are other countries doing in this space? Because there's been a lot of advances, you know, internationally in how they're managing those community-led GMS services. So sounds as if Andy, I want to be involved in this, isn't
it? Katie?
Yeah, a couple of questions from me. You described, obviously you were consulting with him, and then you described something called the wider stakeholder cohort, and I was just curious to know who was in that group. When you talked, I think, Jill, you said about the parameters around how that was going to come back. I didn't hear the word affordability. So I suppose I would be keen to ensure that whatever we're bringing back is affordable and deliverable in that kind of context. And my final question, which kind of you clarified, David, but that bit about if we've got the existing framework as the kind of the framework in which we're operating in, what if there's things that come up that we think, I suppose, need to be escalated to Scottish Government that says this is what we're hearing from GPs and this is what we would want to change if we could change it within, do we have a mechanism to do that? So that's my 3 questions.
So shall I pick up the last one and you guys pick up the so I think the approach that we're taking here and the real drive from my perspective to make this happen came from a bit of national work that was shared probably maybe July, August time last year, maybe June, July time last year, where NHS Grampian, NHS Lothian and NHS Glasgow and Clyde described their approach to GMS review. So we've got that route back into that national network that sits kind of within the Primary Care Directorate of the Scottish Government to share that intelligence back and to help government frame what the future of general medical service looks like, but also allow other boards to learn from that as well. So yeah, absolutely, Katie, as the intelligence comes through, we'll be more than happy to share that back into that national group.
In terms of the second question, was that second?
So the first one was about the state, what was in that wider state?
Yeah, so that's,
and there was the board.
was we going to like clinical leads and senior management team, multidisciplinary teams and etc. Is that's the kind of second set of questions that we had, but in terms of the GP practice questions, the first set of questions.
I suppose my question was coming from the point of, are we asking other people other than GPs what?
Yes,
I was, you know, like
3 sets of questions.
All the service directorates are involved.
Yeah.
Indeed, David Bryson's team as an operational director has been involved in this as well.
Yeah.
And as Lisa said in the presentation, we are casting the net out to the public as well. It's most likely through community council route and providing 2 virtual community council sessions to come and engage with us around that. So we are doing that. That will be built upon during the planning phase. So that June to October piece And we're still probably in the process of the December piece. And I think, you know, Jill popped up a slide and spoke to a slide showing the breadth of stakeholder involvement thus far. And if you accept 12 GP partners took part in that, there were others like any health nurses that took part in that, there were health support workers who took part in that, community link workers. So we're very seeing that breadth of people.
Yeah, Linda?
Thanks, Chair. Thanks for the presentation. Thank you. Perennial challenge we have here is resourcing our workforce, getting people in to do the job, especially now more rural areas. It's the rural region anyway, but there are more rural areas as well, other in Dumfries and Galway. So you spoke about the digital piece. Where does AI, are you thinking about AI coming into that as well?
We're thinking about it. Yeah, this is what
It has to be asked.
So I would say we can't jump to solutions at this.
No.
At this phase. Right, so
Is it there in the mix? That's what I'm not asking.
absolutely yes, and the new Microsoft license is going to help us with that. So the Microsoft Fabric that will come with the new Microsoft license will create an environment within which there will be a data lake for health data in Dumfries and Galloway. Whether that extends to be a data lake for the whole of NHS Scotland remains to be seen, but certainly for Dumfries and Galloway.
Sure.
Sitting on top of that, you have Microsoft Copilot, which is an AI tool that will allow us to write our own algorithms to interrogate that data lake and to use that to proactively identify individuals who benefit from more proactive treatment and care. So yes, in short, AI is something we're very minded about, but we need to see how the scope shapes up and how AI fits with that scope to respond to.
Thank you.
Nicole, and then Kim?
Yeah, I mean, I'm really excited about this work. I think, as Mark says, you know, in terms of access to not just health, but social care as well, and primary care is that front line in terms of it. So it's really, really encouraging to see this work and the structure around about it. And I think it will be interesting picking up a wee bit on, again, some of Mark's points about the different views that might come back from people who work in the service versus how people want to access the service in future, and how we bridge that in terms of the journey and just some of the thoughts of that. I think David's point not to get to the solutions now, but I'm also quite thoughtful of this as another bit of a big piece of work, right care, right place, like adult social care visioning, and how we maybe build some of this engagement and consultation into that adult social care visioning work, just round about just some of that feedback. It's maybe one, David, we can come out with here just to make sure that we've not maybe got the time round about the adult social care visioning because of some of the Scottish Government timelines, but some of this is really just that views that are coming through that are potentially quite different if you're a service user or a service person that's in the service working. So just interested in that as well, Chair.
Thank you.
Thank you. Yeah, I have a couple of questions. It's a really good piece of work so far, so well done there. I think my first question is regarding the different audiences a little bit, David, what you were talking about as well, but do we have any target numbers or numbers in mind who we want to reach, like how many people of the different categories do we want to reach with this consultation? And related to that, in regards to service users or the public, I'm wondering if there is a piece of communication and education being done, because I think a lot of the public, if you say general medical services, I would assume not everybody out there knows what falls under that. So are we doing a comms piece to explain what we are talking about before asking questions?
Yeah. I think certainly that is why we've kind of asked our comms and engagement guys to come and help ensure that we're taking that in the right direction and it's being approached in the right way so that we're absolutely including everybody in it. And in terms of that kind of number, we've not set a metric at the moment just because we're in this initial phase. It is obviously that we're trying to encourage as much engagement as possible at the initial, but making sure that everyone is aware that this isn't their last chance to speak. You know, this is purely us setting out the definition of the scope, and we'll absolutely come back to get an understanding from everybody in those subsequent phases. Yeah.
If I could come back on that, I think in the later phases, once we have numbers or once we have an idea of who is responding, it might be good to plan for lesser heard voices that they are being included and targeted as well.
Yeah, we've spoken about that.
Yeah, we've spoken certainly with colleagues around who would absolutely be, in terms of powerful voices and other groups that would be instrumental in making sure that we're hearing from everybody.
Yeah.
Yeah.
Just on that point, so I think you're absolutely right. I think the questionnaire that we used during Right Care, Right Place was really helpful in terms of us understanding the demographics of who engaged with us. What we built into this timeline is a 3-month period from the end of consultation in December through until presenting to IJB the following March. That would give us a time period when we could do a bit of mop-up. So in analysing that demographic data, if we have deficiencies in any area, we can go out and proactively target and that's what we've got more time to do that at this time. So again, another lesson learned from Right Care, Right Place.
Thank you.
Yeah, just like I say, I think Right Care, Right Place really set us off with a template,
Mm.
which I thought was an excellent piece of work, and I think it gave us a good grounding. I think there are lessons to learn from that, in as much as, you know, I've heard you saying, talking about engagement. I think it's really important we get Rod involved to make sure that that gets communicated appropriately, because what we were hearing was, you've already asked us this once. And what people didn't appreciate was the engagement was us getting their views to make sure that we were able to progress and represent and what their views were, and put them out to communities to then find out which the wider community thought was perhaps the best way forward. So I think that there's lessons to be learned from that, and to make sure that we get that. The other thing is about managing expectations, because as soon as you get to consultation, people have a view as to what they think it might look like. We have to be very clear that one of the things that we said with Right Care, Right Place is, it's not a vote. It's not a, you say you'll get. It's a case of, you say, we'll consider it, we'll look at it, we'll see how it fits within the scheme of things, we'll see what we can afford, and then we'll look at what we can deliver. It provides the best options for the widest number of people. So I think that that's important too. And Kim touched on the range. I like the range of people, or the range of folk who've been already engaged. And again, my question would be, are we looking to reach every GP? Because I think we should. Are we looking to reach everybody who works for a GP? Which I think we should. We can't reach all the community, but we should try to reach as many as we can. So I think the people who interact with the GP practice, these are key. And one of the comments we've made earlier today was, the people who do the job are the ones who have got the best idea as to how to manage it, progress it, improve it, and how we can actually deliver that. So I think that, yeah, really good piece of work, really good start, and I look forward to seeing how that progresses.
I just provide a wee bit of reassurance around that question about engaging every GP practice. So every GP practice has a foster lead, a quality lead, who benefit from funded solutions as part of the new GMS contract. And we see those individuals being absolutely key to engaging with every GP practice. So through our cluster, our 4 clusters in Dumfries and Galloway, we are encouraging those leads to go back into each practice and have those conversations and take the questions in and feedback. We'll continue to build on that as we go, so that it becomes very much, as Jill described, an iterative process of constantly going, seeking those views from each practice and getting them back. But those individuals who have those funded sessions, we see as being absolutely key to delivering that for us.
Thanks, David. Anyone else? Okay, well, thank you for that. I'm sure David have a bit of a recommendation, so it's a case of everyone taking note and looking forward to when you come back to see us in June.
Thank you. Thanks very much.
Thank you very much.
Thanks,
Guys.
Moving on to item number 12, which has been referenced a number of times today, Right Care, Right Place. And we've got Steph with us today, and she's going to update us on what's going on now.
Thank you, and thanks for inviting me along to speak today to give you the update. A bit difficult when you've got a tray of chocolate cakes sitting right in front of you. So if you recall, the IJB made a decision in relation to the future of the temporarily closed Scottish Hospital. And the decision was that we would move to remove inpatient services and create community health and social care hubs. So we have just ended the first phase of the 1 to 3 month period. If you recall, this was a 12-year plan for the community health and social care hubs. So this is, I say, the end of month 3 update.
You'll appreciate that in terms of both the staff that worked at the Scottish hospitals and the public, there needed to be a bit of a cooling off period in terms of that decision. So for that November kind of month, that was where we were at. There was a time to digest for the staff and the public had just put that decision and what the impact might be for communities. What I am pleased to advise though is that in terms of the 1 to 3 month programme, we have delivered in terms of what the specification was. And in principle, that was to consolidate the existing accommodation for home teams or multidisciplinary team, our vaccination programme and the introduction of virtual clinic rooms. So I can confirm that for the 4 areas of Moffat, Thornhill, Kilkenny and Newton Stewart, that has been achieved. The virtual clinic equipment has been delivered and there is accommodation identified. What I would say is that there's a bit of work for us to do in terms of being able to promote the virtual clinic concept, both with the public and with the within our service areas. Before COVID, that virtual clinic consultation took off pretty rapidly. However, we have seen a bit of decline in that, but it's about us revisiting that with services to say that opportunity is there, particularly for people that attending for return outpatient appointments that are 5 minutes or so. And we also have staffing complement available because some people may be comfortable with the equipment and use and other people won't be. So we've made sure that at any given time we would have staffing available to support individuals. Obviously for Moffat, if you remember, Moffat was slightly different in terms of the use of the accommodation. Moffat, we had identified the GP practices in the high street to be relocated. I can confirm that the practice will move up to the hospital site in April, that the plans are afoot. Once the practice is moved in terms of that accommodation, we then need to let the dust settle with that a wee bit, and then we will understand what is then left and available within the Moffat site. So the priority for Moffat was to get the GPs relocated. In terms of months 3 to 6, we have in the background been working with partners, scoping out the bigger aspects in terms of service delivery out in the communities. So in particular, I'd just like to highlight the work round about the day hospice that we've been carrying out with our palliative care colleagues and consultants, and also the work that's been undertaken by our strategic planning colleagues to look at the concept of a rotational day hospice. It's not to be confused with day hospital, whereby we would have access on site to a multidisciplinary team, which could be in terms of a clinical team, but also the kind of holistic team that would sit round about that. So there's work ongoing to scope that up as a full proposal in the background, and we've also looked at the concept of OPAT at Newton Stewart Hospital as well with our nursing colleagues and the OPAT team. We have also been approached by Citizens Advice Bureau and the Care Training Consortium. Citizens Advice Bureau are keen to have a room available in terms of financial advice. Again, it's widening that health and social care aspect to the more holistic concepts of services within a building. And our Care Training Consortium are keen to utilise these hubs in terms of training the carers, sorry for the terminology, unpaid carers, and are keen to come out to the sites within the next few months to do that. So there's ability for them to provide that to local carers in the community in terms of that training. We've also approached the Arts Strategy Group, who is associated with the NHS, and as you walk in the front of this building down to the canteen, you'll see some of the work that's ongoing with photographs and projects. They're keen to work with us to give these buildings a more kind of holistic feel and a well-being feel as opposed to a clinical setting feel. That's the only way I can describe it. It's not about them, as I say, painting the walls red or whatever. It's about them supporting us to give the feel of the building something different than a clinical setting. The other aspects that we, as I say, the work that's been ongoing in the background, we put out a request to all service areas for expressions of interest to come out into the community setting, and we have had expressions of interest from mental health in particular and women's and children's services. So what we need to do now is finalise their accommodation schedules for the clinics that they would like to run from the community setting. And as I say, mental health colleagues and women's and children's, there's aspects that are really keen to do that to get back out into the community. The next phase roundabout sort of is finalising the months 3 to 6 in terms of these proposals. The other aspect that we're really keen to look at is to work with, and I know Alan's not here, the third sector and what we're terming as the front door to the community, whereby within these clubs you would have access to third sector and colleagues that would signpost you or support you before you access the statutory service, whether that be your home teams, whether that be your whatever. That front door concept would be supported by third sector, and where we've got home teams based in these community health and social care hubs, it would make sense for them to be co-located in there. So that's again a big piece of work that needs scoped into as a proposal. So all in all, I think we've got to month 3 and we've delivered on the first phase. This next 3 months is really important because some of these big meteor proposals I think will make a difference out in the community setting. We also need to bear in mind, if I'm perfectly honest, that the accommodation in each of the buildings is different. It's not the same, so again we need to be mindful that while we might be able to run with a service model or test a service model, saying in Stuart, that might not necessarily be replicated in Kubrick just due to the size of the venue and what you can do within the scope of the building. So we just need to be mindful of that, and also need to be mindful if we are looking at 4 community health and social care hubs, what do we do with the rest of the region that have not got this, maybe the facilities available, like there's been opportunities with these 4 sites, how do we then replicate some of that across the region? The other part to be mindful of, obviously, is in terms of the capital cost, because we identified that obviously the GP premises would be the big item in terms of capital funding. Again, dependent on how these buildings need to be reconfigured, we're not looking at, as I say, rebuilding or completely demolishing, but there will be an element of capital funding that may be required to make these fit for purpose for the new service models. From engagement piece, we have made plans with Liz, who was here earlier, just in terms of re-engaging with the public around about the community health and social care hubs. Again, be keen to just make sure that if we are out through the user groups that we had in place before, that there's opportunities for other pieces of engagement to take place. So we probably need to think how we might join that up with some of the discussions you've had earlier. Because again, there may be things that the communities themselves would be keen for us to look at that we've not already captured through the first round of consultation and engagement that took place prior to the decision. So that's it in a nutshell, but happy to take questions.
Stephen.
Not a question, but a thank you at the start of this. I think some great progress being made, and I must admit, I'm really excited about what the community hub model can offer us across Dumfries and Galloway. So I know this is about the right care, right place, and those 4 former cottage hospitals in particular, but making the links that, I've been highlighting all there, that the additional stuff that we're looking at from months 3 to 6, the doing things differently we've spoken about for the whole of the day today. And that East End model, for example, where you've got the third sector, you've got social work, you've got allied health professionals, co-located, but as an active service that are taking people in from a community. And they're doing work within the appropriate points of the community in terms of private clubs, whatever it happens to be, keeping people away from the statutory services of health and social work and social care for longer is absolutely phenomenal. And I think we've got to look at what can work well in an individual community hub and then look at how we replicate that across the rest of the region. So none of these sites might be suitable actually. And if that's the case, that's okay. What can we make suitable in the future? And it's not the be all and the end all, don't get me wrong, but this is a front door model as a community hub. It's more than just a front door. It's just potentially a set of services, volunteering opportunities, etc. And it's something that I think we've really got to continue to invest in. And I'm really pleased to see the work that's been done so far, the speed that has been done with 3 to 6 months. It's really exciting, re-engaging with communities. And I think constantly engaging with communities as opposed to with those big consultations and things. So I'm probably sounding a bit excited by this, but I think this is part of the overall picture in terms of what we do to do things differently as we move forward. So thanks, Steph. Hope that wasn't too gushing, but I'm really quite.
Later, Stephen.
Seriously, this could change the way we deliver things in communities more rapidly and more effectively.
Yeah.
There's a whole lot more that needs to be done with that, but
Yeah, thank you. I agree. Thanks very much for the update, and I think a really great piece of work has gone into this already. So well done on that. I think this transition is obviously it's not a simple one and not an easy one to do. So I think the first 3 months, you know, you've already achieved a lot, and also people involved in it. So pass our thanks on for that as well. I'm just wondering, and I share your excitement about the community aspect. I'm just wondering if we had any early indications of feedback from the communities and also from staff members, because for staff it's quite a big transition potentially as well.
Okay, so the staff programmes, we appreciate that as a result of the decision that there were staff displaced in terms of the permanent post, but the majority of staff through the organisational change process have been redeployed successfully into permanent positions. There will be a cohort of staff, particularly in the west of the region, that have been displaced, and we're working in partnership with staff side and HR colleagues to continue to work directly with individuals and what that might mean in redeployment opportunities. So that for the majority of people, we have been able to successfully redeploy into permanent posts of their choice. And as I say, there's a cohort at the moment where we know that it's a little bit more difficult to do that, but we continue to work on a weekly basis with staff in that regard. In relation to the public, obviously there's the initial kind of flutter of the decision being made. I have reached out to the League of Friends and have met the League of Friends both in Kilcubra and Newton Stewart to gauge in terms of how that was feeling from their perspective, and offered up the opportunity for the League of Friends to be involved in the development of supporting community health and social care hubs as a potential where they can support individual citizens round about their health and social care as opposed to an inpatient in a bed in a college hospital. So Kilcubra has expressed an interest to working directly with us, and Newton Stewart, we're going to also speak to the wider League of Friends community. I've not, I need to touch wood, as I say, there was the initial flutter, but we have no, I'm not aware of any particular challenges or barriers that are coming forth in terms of the community. We might get a better sense once we're back into the groups that we previously engaged with. It feels as if the dust has settled, and we're now at the stage where the signage will come down that removes the word inpatients in hospitals, and the signage will go up to indicate the new beginnings of as it does says on the tin, a community health and social care hub. Whether at that point there may be again a bit of flutter, because then that's like a physical sign, isn't it, that's coming down, so there might be something that triggers, but we're now a wee bit down the line, so it doesn't feel like that, but I'd be as I said, I don't want to tempt fate.
Of course, yeah, it's early days in the transition, yeah, that's definitely.
Yeah, it was a couple of things just to mention. So Steph talked about the need for some capital funding. So just to let you know, as part of the NHS board capital plan, we've got some opportunity to get funding for what they're describing as business continuity kind of processes. So we have included an amount in that for community hubs. So we'll still, I don't think we'll hear back until about kind of end of March, April time, whether we've had that resource. But what we will do is work with staff to see what we can do within the money that we've got available at that point in time. But hopefully we will get this additional money. Again, it'll not be building new hospitals or building new facilities, but it will be able to make the existing facilities a bit better. The other thing that I'd asked Steph to link in with was our charity, our endowment funds. So all of the community hospitals have quite significant balances sitting assigned to them as part of, I suppose, the original kind of intention with the inpatient beds. So we're working through the charity side of things to make sure that although we haven't got inpatient beds, that funding is still available for use. So whilst it can't be used to fund kind of mainstream stuff, it can be used to fund the sort of the nicer thing, you know, the icing on the cake kind of thing, and improve the patient experience and things like that. So there will be some opportunity within that space. And the only other, this was a specific question I had, Steph, and it maybe builds on what you've described in terms of that engagement piece. Do we think there might be, or what stage do we think there might be some sort of positive kind of comms opportunities around some of this, and actually, rather than shying away from saying things are changing in this space, to say actually look at how things have really improved? And I suppose we're probably a little way away from that yet, but I was just curious to
think so. We'd agreed like before Christmas that we wouldn't do anything because we would let the dust settle. So I think now that we've been presented where we are to the IJB, I've spoken to the Right Care Right Place working group, and we've agreed that we would put a briefing out following on from this, just to highlight the ongoing
the
work.
GP move or something might be a,
You know, it's just, you know, some of the work that has been achieved, and the kind of some, and just that we felt this would be an appropriate juncture to do that once we've been presented to do.
Linda?
And if I just come in on that, Alec does have we will issue a comms after this meeting that will probably put a communication out to the public just about the update that we have had today around about Right Care Right Place, just so that and that will be element as well. So that will be issued following this meeting. Sorry, Linda.
No, it's fine, cool, no problem, thanks, Andy. It's important to get the comms bit right, of course. When you're talking about, thanks Steph for the presentation, it's really uplifting and really encouraging. In terms of what we're talking about, kind of all day has been reform and redesign and how we can bring this better, but not costing us too much, Katie, obviously. So, you know, it's a great example of that, and also a great example of flexibility in the community. So, you know, it's not just a one-stop shop, it's a multi-stop shop potentially. And obviously what you're saying, and I'm not trying to preempt going forward, but something that can change and reconfigure depending on the demands of the community and the demands of healthcare going forward. So what we've actually done, not to take credit personally, it's not, you know, it's people do the hard work, the heavy lifting, is created a service that's just much more responsive and can reconfigure really quickly depending on what's going on in terms of healthcare going forward. So I think that's fantastic. I think we really should be pushing that out there. Not in a look what we've done, it's fantastic, but I think it's just to ensure people that actually, you know, change can be a good thing as well as a challenging thing. So just well done. Yeah, brilliant.
It's nice to see it all coming together. It feels like we've talked about it for such a long time. But what I really would like us to acknowledge actually is this has been a really tough process for staff. You know, some of the staff that have been in these 4 cottage hospitals have been there literally for decades. You know, some of them have worked beyond beyond what we would call normal retirement age, and it hasn't been an easy process for them. You know, I tell people all the time, you know, I bring people through the redeployment process, and I've never had one single person in all my years as a rep has come back to me and said, Vicky, I hate this. I want to go back to where I was. You know, and I like that, and I say to staff, please don't be my first. Nobody has. However, nobody comes through this saying, actually, this is really good. I'm really enjoying having all these choices. It's a really tough time, and I just want to make sure that that's acknowledged. That, you know, the staff have been really good and you know, taken, you know, what we've thrown at them and running with it and trying to find the best of a difficult situation for them. We can easily see all of the positives in all of this, but, you know, it takes a lot for them to not look back to the positives that they've had and actually turn things in a completely different direction. So I just want to make sure that they are well acknowledged in a difficult time.
Cool.
And I do wonder if there is something in that, Vicky, absolutely acknowledging that, but actually again, not wanting to tempt fate, but given the scale of change across so many different professions, how do we get, because it's not just about lived experience from the public, it's the lived experience from staff. And that fact that we all are going to have to change how we work and how things happen, and that's going to be happening more and more at pace. And how do we take some of those examples and support people on that journey to see that there is a future that you might not see today, but actually this is going to be, we are going to be taking people out of roles that they have traditionally done for, as you say quite rightly, decades, and saying we're jumping into somewhere different. And how do we tell that story in a really supportive way that we can bring our staff with us, Vicky? Because I do believe, and we've touched on it already, but see some of the digital agenda you touched on in Near Me with other elements. It's not so much the public that's a barrier to some of that, it's us and how we've traditionally delivered our services and how we believe the public want to access services. But actually, it's not one size fits all, but there are people who want to access services differently now. And there is something in what you were saying there, Vicky, about how do we help tell some of those stories about we'll never make it any less anxious, because it would be for all of us, and we need to appreciate that and never play that. But how do we help share some of those stories to let people see that there is a supportive process?
Thanks, Andy. I'm struck at the conversation that we're having with Steph and the previous conversation with Gillian, etc. For me, that GMS piece absolutely has to interlink directly with the work that Steph's doing. So I think my one question would be, how are you going to make sure that both of these programmes talk to each other, so that we're both aware of what each other are doing, so we don't go away down siloed tracks, try to do the same thing, but actually how do we come together to make that value add even better?
Yeah, I think that's really important, and I think one of the concerns that were raised when we were doing Right Care, Right Place was the GP involvement and how was it going to affect that and how was it going to impact upon it. I think one of the things that you said, Steph, was about how to look at other communities in relation to we're delivering these community social and care hubs, and what about the others that perhaps don't have that. And I don't believe, not be for me to determine, but I don't believe that we need to provide the same facility in every location. I think we need to look at what the location is, what it needs, and then perhaps shape our sort of delivery of services and that round that. What some of those other communities have is a cottage hospital whereby they get a different range of services. And what we've said when we did Right Care, Right Places, that's not necessarily appropriate for all at that. So it's the case, I think we need to look at what services do we want to deliver and how do we deliver the right care at the right place to as many people as possible. So I think that's really important. I noticed also that you said that some of the signage has been changed, certainly at Newton Stewart, but is that happening everywhere now?
It's the signs have been ordered for the 4 areas, so they will be, and what we'll do is I said I would reach out to the League of Friends in the first instance so they can maybe engage in the community, like, so they're aware, so it doesn't come as a huge shock and to them, so that the people in the community are aware that there will be signage going up. So they are on order, but they're not physically up yet. As I say, we've got that.
I know we've had the conversation and you had concerns about them being available and being put in before we'd actually started putting things in truck, because obviously people's expectations would be that they were turning up and it would all be there ready. So I think it is timely that we didn't do that and that we sort of do it in a sort of managed way. So yeah.
Back on the GP element, I think that Mark had asked, I just think so. I think these hubs and community directorate are in a very good position to be the interface between the primary care setting into community hubs into acute. So I do see that's where I think we sit. We can very much of that interface and involved directly, because in the middle of it all. So there's opportunities for us definitely, and we work very closely with our GP leads and GP colleagues. And so if I was to stick a rock, I'd probably have the community in a wee bit acute at the bottom. That's how it would be. So I think there is, I suppose, Mark, the workings happen naturally in terms of how we come together, just because of where community directorates sitting at the moment. But I think that will get stronger in the future as we start to really harness the GMS contract part as well. Because this is about primary care as well, and how these hubs are actually can be utilised by primary care as a resource, good resource for the future.
I think Vicky also touched on a very important point. And what we all should always remember whenever we're doing anything like this is that people are at the heart of it all, be it the people we treat, be it the people we employ, be it the people we engage with. So I think that it's really important that we do take that into account and make sure that when we're engaging with our own staff, that they to give you an example, when I had my previous job, we did our job, but then somewhere along the line they said, actually, you're going to have to start doing that. And we said, oh, why am I doing that? I don't want to do that. I don't do it. And we said, well, actually, when we employed you, we said you had to do that. We just said, no, I don't want the job. And I think that sometimes what happens is we get in, we get comfortable, we enjoy our environment, and we just sort of think, right, I'm okay here. And when somebody brings on change, they say, no, I don't. But we'll have new people who will join us under those conditions and they'll be happy with it, comfortable with it. But I think it's that resistance to change, and we have to sort of take our staff along with us. And I think that is a challenge, but it is something that we need to sort of press and encourage. Vicky, you want to come back in?
Two things now, you've given me something else. I remember a good few years ago now talking about change like this and talking about services, and I think the example that was given was, if you think about services like a bicycle, if you keep pedaling and you keep moving forward, and the minute you stop that change and that development, you fall off. So you've got to keep that moving. So yeah, it's a nice way of thinking of it. But Steph, what I was going to ask is, you were talking about the signage.
Yes.
Have the names changed then? Have we made a decision, or how did that come about?
So it's community health and social care hubs.
Okay.
It's basically, we want to keep it as simple as possible. We did go down some rabbit holes, as you can imagine, in terms of what they should be called. So I think it just needs to be simple, and that way that you can incorporate whatever you need into that community health and social care hub service perspective as well.
One last question from me. Last thing with the conversation of saying you were having difficulty getting some buy-in from services to provide facilities locally. How are we doing with that?
I think the particular ones round about the virtual clinics and just that potential that we can unlock that's there. I think we've got a wee bit of engagement to do with our services just to promote that and actually get some of that up and running. We've had some, as I say, interest, but we feel there's much more that could be achieved in that space. So we do need to engage directly with services in that regard.
And again, what I would say, some of the things we talked about earlier today is how do we quantify our performance? And I think it'd be good if after we start to look at how we can quantify it, how we're engaging with, how we're engaging, how many of this, that, whatever, just to show the benefits to communities. And and equally in that, calculate the miles that are saved and the hours that are saved as a means of saying, you didn't have to go to. I mean, I was here yesterday for an appointment that took 15-20 minutes. It took me a damn sight longer to get here and a damn sight longer to get home. So it's like, what are the savings for individuals and the organisation and amongst it? So I think some sort of performance measures in there would be really, really good. Alan, we've just sat and talked about right care, right place and third sector come out. I don't know if Steph, you want to sort of engage Alan in sort of part of contribute to the group.
It's just the East Redfern model of the front door and the community hubs being a place where it would facilitate that concept. So I was just kind of explaining that we would be scoping that out next week, 6 months with colleagues to have a look at that and what that might look like.
Yeah, that was it.
Yes.
In terms of, well, I'm with you, absolutely. I think we've been involved in some of the conversation, so
there are a couple of different models, I suppose, that are around that we want to bring to the table to do that. I'm interested just out of another Scottish Government conversation about reform and community planning support for families, and there's all these other elements I think that we could probably helpfully bring together. But we have also developed, which has been shared with some colleagues already, a kind of overriding concept, if you like, about how the third sector can help organise itself, how we build capacity in the sector to respond to some of those needs, and actually give a greater collective focus on outcomes. Because the sector itself is siloed into activities broadly based on, one, what they would like to do, but two, by funding. So there's lots of work that we need to do to take away some of the competitive nature of funding, for example, and to bring more collaboration to the sector. And I think that feeds in well to some of the ideas of the kind of world door concept and some of the models that are happening across the board. So I think, yeah, we'll kind of have a nice meeting in the middle. Third sector's already started to shape how it wants to respond. There are some models that we're talking about working together. So I think there's huge potential to do that.
Okay. Okay, there's nothing else. Okay. That concludes today's meeting. Not been notified of any other urgent business, so can I thank you all for your engagement, your participation. Things been really good, mate. I think we've got really into the guts of quite a few issues there. I'm really pleased with how things are going, and thank you all once again for your help, support, and participation. Thank you.
Thank you.
Thank you, Chair.
Thank you.
Thank you.
See you, Chrissy.